I am Per Solberg Sørensen. I'm a neurologist from the Danish Multiple Sclerosis Center at the University of Copenhagen. And I'm happy to be invited to give you this presentation on registries in the real-world evidence generation. And these are my disclosure of conflicts of interest. So what is, in fact, real-world evidence? Well, you know, the FDA define real-world evidence as the clinical evidence regarding the usage and potential benefits and risk of a medical product derived from analysis of real-world data. And real-world evidence can be generated from different studies, including but not limited to randomized clinical trials, but also including large simple trials, pragmatic trials, and observational studies, both prospective and retrospective. So how do we get real-world data? Yeah, the main sources are data registers and databases, but also administrative claim data and medical records are used, and recently also the wearable devices can produce data. So when we are using registered data, we can achieve answers to a lot of questions about many aspects of MS. We can use registered data for descriptive epidemiology of MS, looking at the incidence and prevalence and survival analysis. We can also look at the presence of comorbidities and the consequences of these. We can also do what we call analytical epidemiology, where we look at cohort studies to predict the disease course and to examine, for example, changes in the treatment paradigms. Observational studies can compare the effectiveness of disease-modifying therapies, the effect of discontinuation on the risk of relapses and disability progression. We can monitor adverse events and also the adherence and tolerability of disease-modifying therapies. It is perfect for long-term sustained efficacy and safety studies. We can use patient-reported outcomes and pregnancy outcomes. And one important type of studies are the post-authorization safety studies, or PASS. And these are studies that relate to an authorized medical product and conducted with the aim of identifying, characterizing, or identifying a safety hazard, confirming the safety profile of the medical product, or of measuring the effectiveness of risk management measures. And also we can use registered data for big data collaboration. So real-world data provides we can study many therapeutic measures, and real-world data gives us information that are generated in healthcare systems outside of control trials. Usually we think having a hierarchy of evidence in clinical research, where the randomized clinical trials is the gold standard. But clinical trials are not always feasible because of practical or ethical concerns, or the financial possibilities, or a combination of these factors. When we're using real-world data, we do not use blinding and randomization, but uses data about real people under real circumstances, and we can include cases without restrictions. So in observational studies, we do not have any restrictions regarding age, comorbidity, or willingness to participate in a randomized control trial. We can produce long-term outcome data from large cohorts of MS patients with different treatment sequences. We can also contribute to identify predictors of treatment response, either a good or a poor outcome. And we have evidence about comparative effectiveness and the safety of different disease-modifying therapies in real-world setting where head-to-head comparison is not available. We can also capture patient-reported and patient-centered outcomes. We sometimes speak of the efficacy-effectiveness gap. And in fact, when we are looking at randomized controlled trials, these trials are efficacy trials, whereas the observational real-world studies are effectiveness trials. So the randomized controlled trials are narrowly focused. We have more restrictive inclusion criteria. We're usually testing one drug versus another or placebo. We focus on a single primary endpoint, and therefore the studies has less general clinical relevance, but has a very high internal validity. When we look at the observational real-world studies, we can use a broad spectrum of patients. We are less restrictive inclusion criteria. We can compare different active treatments, and we have more than one endpoint. Therefore, we produce more general clinical relevance, and we have an external validity because the outcome measures are more generalizable. I'm going to use data from the Danish Multiple Sclerosis Register, and therefore I'd like to give you some facts about this. You may know that Denmark is a southern Scandinavian country of 5.5 million citizens. And the register was started by Kai Hyllested, and since 1948, data on virtually all patients with onset of MS in Denmark have been kept in the Danish Multiple Sclerosis Registry that contains now data from more than 25,000 patients. Since 1996, all Danish disease-modifying drug-treated patients are followed prospectively with real-time registrations according to a standard protocol. And now the register contains more than 12,000 of these patients. The completeness and validity of the register has been evaluated to be more than 90%. We do not need consent from patients, and we have now notification on all patients with MS treated with disease-modifying drugs, which is mandatory. The operational costs of the register are financed by the Danish Multiple Sclerosis Association and the Copenhagen University Hospital, Rigshospitalet. Whereas the research activities are funded by grants from public and private foundations and legacies. Each multiple sclerosis clinic are entering data directly into the database, and it contains information on all treatments, on relapses, adverse effects, EDSS, which are all stored in the database. And this shows the data entering platform interface of the registry. We have data on the patients, we have the onset of symptoms, diagnosed date, the duration of all different disease-modifying therapies, data on each relapse, on EDSS score at each outpatient clinic visit, the MSS score, and it's also possible, but not mandatory, to store data on MRI, CSF, the SDMT, MSFC, and so forth. And this is done online at each outpatient clinic for each patient. The Danish MS register is linked with other population-based registers, and this is because each Danish citizen has a unique identification number, which is stored in the Statistics Denmark. And via Statistics Denmark, we are connected with the Copenhagen School Health Register, with the Danish Cancer Register and other disease registers, with the Register for Causes of Death, with the National Patient Registry, the Prescription Database, the Civil Registration System, and Twin Registry. So we use the data for descriptive epidemiology. And this just shows review of the incidence of MS in Denmark from 1950 to 2020. And as you can see, the incidence has increased both in men and women, but most in women. And interestingly, it's actually the patients with onset at the age of 40 or more that have increased most. We have also used register data to look at the prevalence and incidence in Western Europe and America by year. And this confirms the increase in prevalence and incidence from 1950 to 2010. We also looked at the sex ratio and found that the female-male sex ratio decreases by increasing latitude. It increases by increasing years and with increasing incidence rates. Interestingly, when we looked at the incidence by the geographic latitude, we could see that the north-south gradient in Western Europe had disappeared, where it was maintained in Australia and New Zealand. The register has also been used to look at the excess mortality among patients with MS in Denmark from the 1950 cohort to the 1999 cohort. And the mortality of MS patients have been compared with the background population. And as you can see, the excess mortality has dropped significantly over the last 6 decades. And today, the life expectancy for a person with MS in Denmark is only 8 years shorter than the background population. This shows a study of comorbidities from the Swedish register in patients diagnosed in 1968 to 2012. And you can see from the upper left that autoimmune diseases are more frequent in MS patients than non-MS patients in the younger age groups up to 60 years. Then it levels out. There are no difference in cardiovascular diseases in MS patients compared to non-MS patients, whereas there is a strong predominance of depression, particularly in the younger age groups, in MS patients compared to non-MS patients. No different with diabetes, but an impressive change in the comorbidity of renal diseases. As you can see, it has really decreased significantly from 1950 until 2012. It is still more frequent in MS patients, but it has decreased significantly. Respiratory diseases are more frequent in MS patients compared to non-MS patients, and so are seizures. If you look at the register data for analytical epidemiology, we looked in the Danish register to evaluate a novel treatment paradigm, early versus later treatment initiations after the first MS symptoms. This was a register-based cohort study based on prospectively collected data, and we looked at patients who have started treatment less than 2 years before the first symptoms compared to patients who have started treatment later. And we looked at the time from treatment start to progression to EDSS-6 and mortality in cohorts, and found actually that if we look at the later treated patients, they had a 42% higher risk of reaching EDSS-6 compared to the early treated patients. There was also a 38% more likelihood for death in the later treated patients, but this difference did not reach statistical significance. In another study, we looked about the paradigm of treatment escalation compared to switching to another moderately effective treatment in 808 patients who switched therapy due to disease breakthrough on a moderately effective treatment and with one relapse within the last 12 months. And some patients switched to a highly effective treatment, and with propensity score techniques, we compared those to those patients who continued with the same therapy or switched to another moderately effective therapy. And if we look at the time to the first relapse, there was a 35% decrease in the risk of having a relapse, which was statistically significant. Whereas there was no difference in the time to 3 months confirmed disability progression. This study was a collaboration between the MS base and the Swedish MS registry, and it looked at early clinical markers of aggressive multiple sclerosis. And they studied 2,403 patients in the MS base and 556 patients in the Swedish MS register. And they were followed for at least 10 years. They defined aggressive multiple sclerosis as EDSS 6 or more reached within 10 years from symptom onset. And this EDSS should be sustained over more than 56 months, and the EDSS 6 or more should also be sustained until the end of follow-up. Overall, 6% of the patients in the MS base and 6% of the patients in the Swedish register had aggressive disease. And if they looked at the early markers, the age at onset was a strong predictor. 35 years compared to patients below 35 years. Also, the EDSS 3 or more within the first year, or the proportion of time on a second-line treatment in the first 10 years. Together with pyramidal signs were strong predictors. Looking at observational studies, registered real-world data can also be used to compare different treatments. We used propensity score methods to adjust for baseline imbalances. And one method is the inverse probability of treatment weights that can use all covariate information to determine the probability of each subject receiving a specific treatment. In one study, we compared teriflunomide and dimethyl fumarate. In all, 2,236 patients started treatment with either teriflunomide or dimethyl fumarate. And using the propensity score matching, we showed that the relapse rate ratio between the dimethyl fumarate and teriflunomide was 0.6, meaning that there was a 40% lower risk of having relapses on dimethyl fumarate. Also, the time to the first relapse was statistically significant, whereas the time to 6 months confirmed EDSS score worsening only showed a minor difference that was borderline statistically significant. We also compared patients treated with natalizumab and fingolimod. Between 2011 and 2015, 1,139 patients were treated with either natalizumab or fingolimod. And we used propensity score and achieved two treatment arms with 464 patients in each. And the on-treatment annualized relapse rates were 0.2 for natalizumab and 0.3 for fingolimod. And as you can see, the two drugs were practically even in terms of on-treatment annual relapse rate, the time to first relapse, and the change in EDSS. The same proportion worsened, were unchanged, or improved in EDSS. However, other studies have also compared natalizumab and fingolimod, And this is just shows the 4 largest studies with between 87 and 998 patients. And whereas our study showed no difference in the effect on the relapse rate, the 3 other studies showed a superiority of natalizumab, whereas there was no difference in looking at the effect on 6 months disability progression. Another important use of register data is the post-authorization safety studies, or the PASS studies. This was an initiative of the EMA, and there has now been a harmonization of data collection across different registers using the METRA coding for adverse events and serious adverse events. So MS registers, together with pharmaceutical companies, have agreed on a common safety protocol standardized approach. And this is just an example of a cohort of teriflunomide-treated patients with a collaboration between Denmark, the Lombardy, Belgium, and France. And the primary objective was to characterize the long-term safety profile of teriflunomide and to determine the incidence of adverse events of special interest in a real-life setting. And these adverse events of special interest include acute liver injuries, infections, interstitial lung disease, pancreatitis, opportunistic infection, malignancies, peripheral neuropathies, cardiovascular events, and all-cause mortality. And the secondary objective was to describe the patient's characteristics and utilization patterns of teriflunomide in a real-life setting, and to evaluate whether teriflunomide treatment is associated with an increased risk of any of the adverse events of special interest compared to other approved MS treatments. Finally, we can use register data for big data collaboration. And this is a study under publication. It's a comparison of natalizumab or fingolimod in the 3 largest studies that was performed with data from the French and the Danish registers and the MS space. So in all, 5,148 patients were followed for 25 months. And we looked at, for relapses, the natalizumab fingolimod ratio was 0.77, meaning a significant 23% reduction in relapses with natalizumab compared to fingolimod, whereas there was no difference in the sustained EDS worsening. And we also looked at different subgroups, and again, there was a strong trend and many significant differences when we looked at the natalizumab fingolimod effect on relapses, whereas there was no difference when we looked at 6 months confirmed disability worsening. A very big MS PASS study has just been initiated. And regulators, pharma, and MS registers have jointly identified a collaboration on PASS for MS disease-modifying therapies. So the core protocol registers analyze their own data. And then the aggregated results are made available to sponsors and authorities for customized data analysis. So there should be an improved capture of adverse events, in particular cancers, and non-melanoma skin cancers, and immunosuppression-related infections. All are meta-coded. And we use the EuroCAD codes for pregnancy outcomes. Originally, several registers have joined this study, and additional MS registers are welcome if they fulfill the study criteria. And I would like to thank my colleagues at the Danish Multiple Sclerosis Register, in particular Dr. Melinda Madiari, and I would like to thank you all for listening.